we do at PW MedEd before every INI session. So this is for the targeted May 2026 session. So here the idea behind these PYQ series is that we all know that INICET is a very PYQ and PYT, that is previous year questions and previous year topics heavy exam. It's very easy to crack that exam if you have a strong hold on these selected topics. So for this session also, I have curated questions in such a form that we cover most of the previous year topics. So a very good evening to everyone. So let us just not waste any further time and start this series, right? So we start with this first question. It is a short stature question, which is an age-old favorite of INI people. So I have a 6-year-old whose upper segment lower segment ratio is 1.4:1. The short stature is characteristic of, and we have 4 options over here: growth hormone deficiency, spondyloepiphyseal dysplasia, constitutional delay in growth and puberty, and the last option is achondroplasia. So remember, whenever we are evaluating short stature, the first step here would be to know whether this is a proportionate short stature or a disproportionate short stature. Right? So proportionate means proportionately the child is short. The upper segment, lower segment, the entire body is affected equally. Proportionately the child is short. Disproportionate means either the trunk is short, short trunk dwarfism, or the limbs are short, short limb dwarfism. To know whether this is a proportionate short stature or a disproportionate short stature, you need to know about this ratio, that is the upper segment lower segment ratio. So let's dive into the basics. What is upper segment? What is lower segment? So what is upper segment? If you take the height from the top of the head till pubic symphysis, this is the upper segment. And if you subtract this upper segment for the entire height, you get this lower segment. On the other hand, you can also calculate this upper segment by calculating the sitting height of this child, right? Either ways we can measure this upper segment lower segment ratio. What is important for us over here? So we know that the direction of progression of growth is cephalocaudal in direction. That means firstly your head will grow, then your trunk will grow, then your limbs will grow, right? So my upper segment is basically my head and the trunk. So when the child is small, that means when the child is born, the upper segment is going to be big as compared to the lower segment, and as the child grows, my lower segment will grow. So this ratio, upper segment lower segment ratio, will be high at birth and it will fall as the child grows. So let us know that the normal upper segment lower segment ratio values. So at birth, this upper segment lower segment ratio is 1.7:1. By 3 years of age, it becomes 1.3:1. By 6 years of age, it becomes 1.1:1. By 10 years, it becomes 1:1. And after that, the adult ratio of 0.9:1, or we can also write 1:1.1 is achieved. So this is the normal ratio. If this ratio is normal for that short stature, it is a proportionate short stature. But if this ratio is high or low, then we suspect disproportionate short stature, right? So let us understand both the scenarios. So upper segment lower segment ratio, if it is high, what do I mean by high upper segment lower segment ratio for the age? That means my trunk is big, limbs are short. So this is short limb dwarfism. Short limb dwarfism. In this condition, remember 3 differentials. This you should mug up by heart. If I wake up you in the sleep, you should also be able to recall these 3 causes, right? What are these 3 causes? First is rickets. Second is achondroplasia. And third is your congenital hypothyroidism, right? Then comes the other scenario where this upper segment lower segment ratio is actually lesser for that age. That means my trunk is short. This is short trunk dwarfism. right? And we all know our trunk is basically our vertebra and the rib cage. So any problem with the vertebra, any problem with the spine can lead to this short trunk dwarfism. So let's list down these causes. Firstly, vertebra, right? So any vertebral anomaly can lead to this. TB spine, that is spot spine. Storage disorders like mucopolysaccharidosis and spondyloepiphyseal dysplasia. Spondyloepiphyseal dysplasia. Right, so here we have listed and have an overview of disproportionate short stature. Now let's go back to our question. Our question said that we have a 6-year-old whose upper segment lower segment ratio is 1.4:1. I know that at 6 years, what should be the ratio? At 6 years, the ratio should be 1.1:1. That means here the upper segment lower segment ratio is high for that age. That means I have a bigger trunk and shorter limb. This is short limb dwarfism. And out of the options, which is the short limb dwarfism? I told you 3 conditions: rickets, achondroplasia, and congenital hypothyroidism. So achondroplasia is the correct answer over here. Let's dissect other options too. Growth hormone deficiency. Growth hormone will proportionately affect my child. So upper segment lower segment ratio should be normal over here. What about spondyloepiphyseal dysplasia? Here again my spine is affected, so this is short trunk dwarfism. Here you are going to have less upper segment lower segment ratio. In constitutional delay in growth and puberty, this is a physiological short stature. Again normal upper segment lower segment ratio for that age. Right? So the correct answer over here is achondroplasia. Now let's move to the next question. We have a 1-year-old healthy male infant who is brought to your clinic for growth monitoring. If his birth height was 50 centimeters, what is the expected height now? 100 centimeters, 75, 65 or 70 centimeters? Very straight away, very factual question, right? So we all know what is the average length at birth. The average length at birth is nothing but 50 centimeter. Now how this grows? This 50 centimeters in the first year of life, the child gains 25 centimeters. So by the end of 1 year, the height would be 75 centimeter. In the next year, another 10 to 15 centimeters is gained. So by the end of 2 years, it would be 85 to 90 centimeters. Then the child gains around 6 centimeter per year till puberty. At puberty, the child is again going to have a spurt. So males can grow up till 10 centimeter per year and females can grow up till 8 centimeters per year. Right? So this is about the increase in the height or length. So now let's go into the basics. I have 2 devices over here, device A, device B. Device A, I use to measure length. I make the child lie down like this. It has a fixed headpiece and a mobile, flexible other end, right? That is going to rest on the foot of the child. By this, I'm measuring the length of this child. This device is known as Infantometer, right? This I use for a child less than 2 years of age. Now you might ask me, ma'am, the name itself has Infantometer and we know that by 1 year of age the child can stand. So why cannot I use this device and measure the height? Why I am still measuring the length? Because till 2 years of age we have physiological bowing of legs. So till 2 years you are going to use this Infantometer and measure the length. After that you are going to measure the standing height of the child, and the device for measuring this height is Stadiometer. Stadiometer, right? So what would be the correct answer over here? 75 centimeter B, right? And we also covered some of the associated questions. So now let's move to the next question. At routine checkup, mother asks when she can expect her child to show a consistent preference for using the right hand. You inform her that this milestone occurs at 18 months, 2 years, 3 years, 5 years. In this question, the mother is essentially asking, handedness, about handedness, that when does the handedness appear. So we all know either you are right-handed or left-handed, but it was not always like this. Initially, the child is using both the hands. The child is ambidextrous, and after a period of time, the child develops a preferential usage of one side. If the child is right-handed, he will develop a preferential usage of the right hand. If left-handed, left hand, right? So when does this handedness comes? Remember, this handedness comes by 3 years of age. Isha Thakur is correct. The handedness comes by 3 years of age. And what about left to right discrimination? Left to right discrimination, remember, comes by 4 years of age. So don't confuse between the two. If the child starts using right hand more than the left, this is handedness. But when the child is able to differentiate that this is right, this is left to right discrimination. So this left to right discrimination, it comes by 4 years of age, right? So this is the basic concept, the developmental milestones they're anyways going to ask. So this is one of the favorite questions, handedness and left to right discrimination, they have asked multiple times. So don't forget to mark this wrong at least. Another milestone question. We have a 9-month-old infant who cannot sit without support. He can roll over and say dada. Mother is worried about the delay. Your next step is option A, refer for the neuro assessment immediately. Option B, start intensive physical therapy. Option C, reassure as the upper limit for sitting is 10 months. Option D, reassure as the upper limit for sitting is 12 months. So let's dissect this question. I have a 9-month-old infant with me. At 8 months, we all know, at 8 months, usually sitting without support comes, right? Sitting with support comes at 6 months. And sitting without support comes at 8 months. So this child cannot sit without support. That means this milestone has not happened. But he can roll over. That means he has achieved this 5 to 6 months milestone. And he can also say dada. Dada is bisyllable, right? So monosyllables, bisyllables usually come around 9 months of age. So the child can say that. So that means most of his milestones are appropriate. Just this gross motor milestone is slightly delayed. Whether this delay is significant or not, how do we know? We should remember the upper limit of age, right? If the child is not sitting at 8 months, does not mean that this is delay. Child can sit 15 days after 8 months. Child can sometimes sit before 8 months. So a delay is said when the upper limit of that age is achieved. So let's look at this table that is given in Ghai textbook of pediatrics. So it has given upper limit of age of the attainment of milestones. When this upper limit has crossed, then we go for neurological assessment, right? So you can see over here, sitting without support, the upper limit is 10 months. So here the answer would be that I will reassure the mother that please wait for 1 month more, as the upper limit of age for attainment of this milestone of sitting is 10 months. So option C is correct. Reassure as the upper limit for sitting is 10 months, right? Let's move to the next question. During a 4-month-old well baby visit, you are monitoring the head circumference. If the birth circumference was 34, what is the expected measurement at this visit? The options we have are 37 centimeter, 40 centimeter, 41 centimeter, 43 centimeter. So essentially the examiner is trying to test whether you know how the head circumference grows after birth or not, right? So can you tell me what is the normal head circumference of a term baby at birth? So we all know that the normal head circumference at term, the baby, a term baby at birth is 33 to 35 centimeters, right? So let's see how this head circumference now grows after birth. So how do we measure the head circumference? We take a measuring tape, place over the head of the baby. Anteriorly, it should lie just above the supraorbital ridge, that is just above the eyebrows, and posteriorly it should be on the highest point of the occiput. So in the initial 3 months, how does the head circumference grow? In the initial 3 months, it grows 2 centimeters per month. In the next 3 months, it grows 1 centimeters per month. And in the next 6 months, it grows 0.5 centimeters per month, right? So here I have a 4-month-old well baby. So in the first 3 months, the child would have gained 2 into 3, that is 6 centimeters. And after that 1 month, he must have gained 3 centimeters, he must have gained 1 centimeter. So total 7 centimeter gain should have been there. They have given that the birth HCU is 34. So 34 plus 7 is 41 centimeter. So Nayak, you are right. Ayush. So Ayush is asking, what if after 10 months he is not able to sit? So firstly, we have to, in the neurological assessment, we go to evaluate the cause why this child is lagging behind one milestone, right? We will do proper formal motor assessment, sensory assessment, and also we'll take into factors like any metabolic illness, any other signs. So a thorough neurological assessment would be there, right? That is beyond the scope for right now for you. If you go into MD Pediatrics, we have a thorough neurological panel for such patients, right? So what's important for you at your level is to recognize that this is a red flag and it requires thorough assessment. Okay, so we are done with this question, rate of increase in head circumference. Let's move to the next question. So using a Shakir tape, a healthcare worker finds out that a 3 years old MUAC is 12 centimeter. What is the interpretation over here? This is severe malnutrition, red zone, undernutrition, yellow zone, normal nutrition, green zone, or borderline normal, green zone. So what is this Shakir tape? This colorful tape here is Shakir's tape, right? So we use this tape for screening of malnutrition. So this is a screening tool that we use. Even if you don't know how to read numbers, you can just, by looking at the color at which the overlap is there, you can tell whether this is severe malnutrition, undernutrition, or not malnutrition. So here you can see 3 colors. So we have a red zone, that is less than 11.5 centimeters. We have yellow zone, which is 11.5 to 12.5 centimeters. And we have green zone, which is above 12.5 centimeter. So this red zone indicates that this child is severely malnourished. Yellow zone indicates malnutrition or undernutrition, and green zone means normal nutrition, right? What we are measuring with this? We are measuring MUAC, mid upper arm circumference. What is this mid upper arm circumference? So mid upper arm circumference is an age independent parameter that we use to assess growth of the child, nutritional status of the child. So how do we measure? So if this is the child's arms, I will take 2 bony point above acromion process and below olecranon process. I will make an imaginary line joining these 2 points, and at the middle of that is the point where I measure this mid upper arm circumference. So why this is age independent? So in between 6 months to 5 years of age, what happens? And this is the arm, cylindrical arm. Initially the child is very chubby, right? There is a lot of fat, and as the child grows, this fat is reduced, this baby fat is reduced, and muscle grows. So overall in this age group, fat is reducing and muscle is growing. So overall circumference remains the same. So that's why it is an age independent parameter to assess growth. So this is the interpretation. Here they told us that the 3-year-old's MUAC was 12 centimeter. That means the child was lying in this zone, yellow zone. That means, which is the correct answer? Option B, undernutrition, yellow zone. It would have been severe malnutrition, red zone, if it would have been less than 11.5, and green zone if it would have been more than 12.5. This borderline normal does not exist, right? Either we have green, yellow, or red. Severe nutrition, undernutrition, or not malnutrition. Very straightforward question. Now let's move to the next question. Under the National Vitamin A Prophylaxis Program, what dose should be administered to a 24-month-old child? Options we have are 1 lakh units, 2 lakh units, 50,000 units, and 3 lakh units. Very basic, you should know, right? So what is the vitamin A prophylaxis dose? If the child is less than 6 months, it is 50,000 international units. 6 months to 12 months, it is 1 lakh international units. And after 1 year, that is after 12 months, it's 2 lakh international units, right? And the catch over here is that if the child is above 1 year of age but the weight is less than 8 kg, then we go for the half dose, that is 1 lakh international units. So they have simply asked us in the question, we have a 24-month-old child, that means a 2 years old child, what would be the dose? So simple, straightforward, it would be 2 lakh international units. 2 lakh international units, option B, right? Option B. It is a 24-month-old child. Option B is correct. It's 2 lakh international units. Okay, so with that, now let's move to the next question. All children below can be diagnosed with SAM except we have a 2-year-old child with kwashiorkor, 4-year-old child with weight for height -3 standard deviation, a 7-month-old child with MUAC 11.4 centimeter, and a 2-year-old child with weight for age -3.2 standard deviation. What do you think would be the correct answer over here? The criteria for SAM, the definition for SAM, remember, what is the criteria for SAM? Let's recall together. So when we talk about the criteria for SAM, we need any one out of three, right? Any one out of the three. First, severe wasting, that means weight for height less than 3 standard deviation. This is severe wasting. Then second is MUAC. Definitely in 6 months to 5 years old child, we can check this MUAC. If it is less than 11.5 centimeter, it's SAM. And lastly, nutritional edema. Nutritional edema. So now let's go back to our question. A 2-year-old child with kwashiorkor, that means edema is there. So this is definitely SAM. Second option is 4-year-old child, weight for height -3 standard deviation. This is again SAM, wasting. 7-month-old child with MUAC 11.4 centimeters. So here the MUAC is less than 11.4. This is definitely SAM. Now look at the last option, a 2-year-old child for weight for age -3.2 standard deviation. So weight for age is not in the criteria. The criteria includes weight for height, wasting, not weight for age, right? So this is not included in the SAM. So option D is something which is not SAM. So all other three are SAM. Option D is not SAM. Right? So I hope this SAM criteria concept is very well clear, right? We need anyone. Remember, anyone I would need. Anyone, if I get, this is SAM. Okay, so now let's move to the next question. Primary failure of the SAM treatment in an inpatient facility is defined if the child fails to regain appetite by day 2, day 4, day 7, day 10. So what the examiner is trying to test over here? The examiner is trying to test whether you know what is failure to respond to therapy in SAM. So whenever we admit a child with SAM, we have two phases of the treatment. Inpatient treatment SAM has two phases. First is the stabilization phase, where I'm going to stabilize this child, right? Deal with the complications of the child, electrolyte problems or any other medical complications of this child. And then we have rehabilitation phase, where the main goal is to regain the muscle lost weight. So in the stabilization phase, usually by the end of day 4, the child's appetite should be come back, and also the child should start losing edema. And by day 10, all of the edema should be gone and child should start gaining weight. So when do we call failure to respond to therapy? We have something that is known as primary failure and something that is known as secondary failure. So let's understand these two. So what is primary failure? So I told you the initial phase is the stabilization phase. This is for the first week, day 1 to day 7, right? So if the child is not responding in this phase only, then this is primary failure. And what is secondary failure? When the child went through the stabilization phase, went into the rehabilitation phase, and now the child is not gaining weight, this is secondary failure, right? So if initially the response is not there, this is primary failure. If the response is not coming afterwards, when we want the child to gain weight, that is in the rehabilitation phase, that is the secondary failure. So the primary failure, the definition is that by the end of day 4, the child fails to regain appetite or fails to start losing edema, or by the day 10 if the child still has edema and not gaining weight 5 gram per kg per day. And what is secondary failure? In rehabilitation phase, if the child is not gaining 5 gram per kg per day for 3 days, that's secondary failure. So here the examiner was asking that it is primary failure when the child fails to regain appetite by, the answer is day 4. Day 4. Option B. Right? So just remember, failure to respond to therapy, we have primary failure, secondary failure. Primary failure by day 4 if failure to regain of appetite and fails to start losing edema. Day 10 is presence of edema and not gaining weight. Secondary failure, not gaining weight in the rehabilitation phase for 3 consecutive days. So with that, now let's move to the next question. Which observation during the breastfeeding indicates proper attachment? So they're asking what are the signs of good attachment, proper attachment. Option A says only nipple inside the mouth. This is wrong, right? Nipple as well as areola should be inside the mouth. Option B says upper areola is more visible than the lower areola, which is true. This is a sign, good sign. Lower lip of the child is inverted, which is false. It should be pouted out. It should be everted. Baby's chin away from the breast. This is again wrong. Baby's chin should be touching the breast. So now let's visually understand the good and poor attachment. So look at here the good attachment outside appearance. Baby's mouth is wide open. Look at the lower lip. Lower lip is everted. What about areola? Areola, lower areola is not visible. And last, baby's chin is touching mother's breast. Right? So here, what is the correct option? Option B is the correct. Upper areola more visible than the lower areola. All other options show incorrect or poor attachment. Right? Ayush is right. Dheeraj is right. Option B is the correct answer over here. Now let's move to the next question. A 29-week preterm neonate is stable. The mother of this child is unable to provide excess breast milk. According to standard guidelines, what is the best alternative for feeding this baby? Option A, preterm formula milk. Option B, pasteurized donor human milk. Option C, soy-based infant milk. And option D, fortified cow's milk. So remember, mother's own milk is the best, right? Mother's milk is the best. So if mother's own milk is not available, second, I will go for donor human milk. If donor human milk is not available, then I will go for formula milk, right? And animal milk is out of the question. Out of the question. We don't recommend giving any other animal's milk to the baby. So the correct answer over here, if mother's milk is not available, I will go for the second best, that is donor human milk. Option B. Option B. Option B. Right? Now let's move to the next question. A 30-week preterm neonate is born via emergency LSCS. After initial steps, baby is gasping with the heart rate of 80 beats per minute. You start a positive pressure ventilation. Which of the following is the most effective, most sensitive indicator that your ventilation is affected? Option A says a rapid improvement in SpO2, that is saturation and skin color. Option B says a rise in the heart rate. Option C says vigorous spontaneous respiratory efforts. Option D, sustained heart rate between 60 to 100 beats per minute. So what is happening over here? The examiner is essentially testing your knowledge of NRP, Neonatal Resuscitation Protocol. So whenever I teach NRP, I tell students that babies are born with a good heart and bad lungs. So I will focus on good heart, bad lungs. That means bad lungs need me first, right? Whenever adult collapses, what do we start? We start chest compression straight away. But here, remember, babies are born with a good heart. You don't need to go to start with chest compressions firstly. You ventilate first because they have bad lungs, right? So my cornerstone of NRP is effective ventilation. So remember the statement that cornerstone of NRP is effective ventilation. If your ventilation is affected, your heart rate will increase. And that's why a rise in the heart rate is the most effective sign, most sensitive indicator that your ventilation is effective. Right? A rise in the heart rate is the most effective, most sensitive sign that your ventilation is effective. Right? Other options are not a sensitive indicator. A rise in the heart rate is the most sensitive indicator. So let's revise NRP together. So this is the new NRP plan. So we all know after birth, we do delayed cord clamping. That is, we wait for 60 seconds before clamping the cord. This allows some extra amount of blood going to the baby. It will not help the baby right now, but in future it decreases the chances of anemia in the babies, right? So after that, you check 3 things: term, tone, cry. If answer to any of these questions is no, you go towards initial steps of resuscitation. You position the baby, dry the baby, stimulate the baby. And if after the initial steps of resuscitation, the baby is apneic or gasping, or the heart rate is less than 100, you start with positive pressure ventilation, which is now just ventilation as a term in NRP, right? Earlier we used to say PPV, positive pressure ventilation, but now the recent update has replaced this term PPV with just ventilation or assisted ventilation. So we start ventilation, and this should be started within 1 minute. That is the golden 1 minute. We go for this effective ventilation for 30 seconds, right? If this ventilation is not effective, chest rise is not there, you go for ventilation corrective steps. And after 30 seconds of effective ventilation, you check the heart rate again. If the heart rate is still less than 100, you start, if the heart rate is still less than 60, you start with chest compressions. After 1 minute of this chest compressions and coordinated breaths, if the heart rate is still less than 60, you give epinephrine. And if even after 3 to 5 doses of this epinephrine, the child is not responding, rule out 2 options: pneumothorax and blood loss, that is shock. Right? So this is the basic of NRP. Now let's move to the next question. You're performing the MR SOPA steps because of the poor chest rise during bag and mask ventilation. You have repositioned the mask, readjusted the head. What is the very next step that you should perform? A. Increase the inflation pressure. B. Suction the mouth and nose. C. Suction mouth and nose and slightly open the mouth. Switch to an alternate airway like ET tube. So Anthony Jacob has asked, can we give PPV in CDH? Yes, you can give, but you cannot give through bag and mask. You have to intubate the child and then give. Definitely you can give PPV, but the mode will be different. Bag and mask is not recommended. Bag and mask is contraindicated, but you can intubate the child and give positive pressure ventilation through ET tube. So here we are testing the ventilation corrective steps. So we all know MR SOPA. What is MR SOPA? M is for adjusting the mask. R is for repositioning the airway or repositioning the head of the child to open up the airway. S is for suction mouth and nose. O is open the mouth, and P is increase the pressure or use alternative airway. Right? So here in this question, they have said that because of the poor chest rise, they started ventilation corrective steps. They have repositioned the mask, they have readjusted the head. So MR step has been done. The next step is suction the mouth and nose. Now you can ask me, why not C, ma'am? C also says suction mouth and nose, and the second step also open the mouth. Why C is not correct? Because remember, this MR SOPA step have to be sequential. If after readjustment of the mask, still chest rise is not there, you go for reposition of the head. If after reposition of the head still not going, then go for suction. If after suctioning still the chest rise is not there, then you open the mouth. So this has to be step by step. This has to be sequential. Step by step. You do not do two steps together, yeah, right? It should be sequential. So remember, that's why option B over option C. Ayush is right, Dheeraj is right. Answer is B, suction mouth and nose. Now let's move to the next question. We have a 4-week-old baby who presents with persistent unconjugated jaundice. Baby is exclusively breastfed and otherwise healthy. The proposed mechanism for this jaundice involves increased enterohepatic circulation via alpha-fetoprotein, inhibition of the bilirubin conjugation by free fatty acids, deconjugation of bilirubin, or inhibition of hepatic uptake by pregnenolone. So what is this? What type of jaundice is this? This is an exclusively breastfed baby who is healthy but at 4 weeks still has unconjugated jaundice. So what is this? This is nothing but breast milk jaundice. So let us just revise these two terms which are associated with breast milk. Breast milk jaundice versus we have breastfeeding jaundice. So breastfeeding jaundice is very simple. The name itself has feeding in it, right? So something related to feeding that has caused the jaundice. So here what is happening? Mother is not adequately feeding this child. So this child is dehydrated. So because of the dehydration, the child has high levels of unconjugated bilirubin, right? Here what will I do? I will ask the mother to improve the hydration status of the baby, ensure regular feeds, right? So here we will continue the breastfeeding and then reassess. On the other hand, what is this condition? Breast milk jaundice. The name itself has milk in it. That means something in the milk that is causing the jaundice. So there are different theories regarding it. First theory says that milk containing high amount of free fatty acids can actually inhibit the bilirubin conjugation and thus lead to increased amount of unconjugated bilirubin. Second theory says that there can be some substances in the breast milk like enzymes that break down the conjugating enzyme beta-glucuronidase and thus lead to high levels of unconjugated bilirubin, right? Some say that there can be affection of the enterohepatic circulation. So if you look over here, the most appropriate answer turns out to be B. C is also partially correct, but they have not mentioned beta-glucuronidase enzyme or something like that, right? Just a simple statement, deconjugation of bilirubin. It is an open statement. So the most correct answer over here is going to be inhibition of bilirubin conjugation by free fatty acids. This is breast milk jaundice. Breast milk jaundice. So these PYQs are from the past 5 years, a mixed bag of questions since last 2021 November session, right? So let's move to the next question. We have a term neonate who is born via elective cesarean section, LFCS. He develops tachypnea, mild retractions at 2 hours of life. The FiO2 of 30% is required. X-ray shows fluid in the interlobar fissure. What is the expected prognosis? So firstly, tell me the diagnosis over here. We have a term baby who's born via elective CS and he develops tachypnea and mild retractions at 2 hours of life. And by 30% of FiO2 he is almost settled, and X-ray shows a typical fluid in interlobar fissures. What is this? This is nothing but TTNB, that is transient tachypnea of newborn. So what happens in this condition? A term baby who is born via elective cesarean section. Normally, if there is a vaginal delivery, what will happen? The baby will be squeezed through the narrow vaginal canal. But in elective cesarean section, because the baby is not going through that passage, there can be some retained fluid in my lungs which can cause this tachypnea and distress. And eventually this fluid is resorbed and this condition improves. The name itself has transient in it. So usually this respiratory distress settles by 6 to 8 hours. Maximum it can go till 48 to 72 hours. So that's what they are asking. They are asking what is the prognosis of this TTNB child. We know this child will resolve within 48 to 72 hours. Let's look at other options. Likely progression to RDS requiring surfactant. This seems to be a wrong option. Why? Because it is a term baby and no other factor suggesting RDS is there. Option C, high risk of developing persistent pulmonary hypertension. Persistent pulmonary hypertension is usually seen when the child requires very excessive amount of ventilation, right? But and prematurity. But here the FiO2 30% is settling this child. So again, this seems to be wrong. Symptoms usually resolve within 12 to 24 hours. So remember the timeline. By 6 to 8 hours, most of them settle. Maximum limit is 48 to 72 hours. So better options would be option B, resolution within 48 to 72 hours. Right? For TTNB, just remember these three things. A term baby born via elective cesarean section. No other risk factor should be there. Right? And usually these children don't have a severe respiratory distress. Very rarely they have severe respiratory distress and require extensive ventilation. Most of them settle. This is the typical X-ray that you see in cases of TTNB. What do you see? Essentially, I'm seeing a retained fluid in the lungs. Can you notice this in interlobar fissure? There is fluid. Horizontal fissure, I can see retained fluid. Also, you can see retained fluid streaking out like this. This is sunburst appearance. So remember, in the X-ray of transient tachypnea of newborn, I see two things. First is the sunburst appearance, that is the perihilar infiltrates. So sunburst appearance. And I have fluid in the horizontal fissure. Typical X-ray pattern of transient tachypnea of newborn, right? Apart from that, let's just revise two other conditions, respiratory distress conditions that you are going to encounter in neonatal population. So firstly, in preterms, what do we see? We see RDS, that is respiratory distress syndrome or hyaline membrane disease. This is due to surfactant deficiency. And here in the X-ray, you are going to see ground glass appearance. The treatment here would be giving CPAP therapy and in case of severe distress, surfactant therapy. In postterm babies or in distressed babies, meconium stained liquor babies, you are going to see meconium aspiration syndrome. In meconium aspiration syndrome, different patterns of X-rays can be there. There can be hyperinflation, segmental collapse, there can be chemical pneumonitis like picture. Ball valve mechanism can lead to hyperinflation of a segment. All of these things can be seen in cases of meconium aspiration syndrome. So now let's move to the next question. According to AAP, American Academy of Pediatrics, this is not Aam Aadmi Party, it is American Academy of Pediatrics. Which of the following is the mandatory lab criteria for perinatal asphyxia? We have the options: umbilical arterial pH less than 7.2, umbilical arterial pH less than 7, APGAR score less than 5 at 1 minute, APGAR score 0 to 3 at 1 minute. So now let us revise the definition of perinatal asphyxia. What is happening in perinatal asphyxia? Baby essentially did not cry at birth, or during the time of birth something has happened that has led to asphyxia. That means decrease in the oxygen. So I have three definitions with me. First definition was given by WHO. Very simple definition. What is this definition? WHO says if the child failed to initiate breathing or failed to sustain breathing, this is perinatal asphyxia. So very simple, right? WHO came with a simple definition. If the child fails to initiate breathing or sustain respiration, this is nothing but perinatal asphyxia. Then came NNPD. What is NNPD? National Neonatal and Perinatal Database. What they said? They said that this should not be a simple definition. Let's make it something tricky for the medical students. So they gave these two definitions. Firstly, they told that I will use this score, APGAR score, at 1 minute. So if at 1 minute of life APGAR score is 4 to 6, or the child has slow breathing, gasping respiration, this is moderate asphyxia. And if at 1 minute the APGAR score is less than 4, or the child is not breathing, this is severe asphyxia. Right? Simple. So NNPD again gave this simple definition depending upon the APGAR score and the breathing status. If it is 4 to 6 and slow breathing, gasping breathing, moderate asphyxia. If it is less than 4 and the child is not breathing, this is severe asphyxia. Remember, these APGAR scores that NNPD gave was on the basis of the status at 1 minute, not at 5 minutes. AAP used at 5 minutes. So what is AAP doing? So AAP essentially said that we all know that in perinatal asphyxia there is hypoxia, decrease in the oxygen. So what will happen if the oxygen is less in my body? I will do anaerobic respiration. And we all know this byproduct of this anaerobic respiration is lactic acid. So my body is going to have acidosis. We have profound acidosis, pH less than 7. Also, different organs of my body will be affected. Most important organ that requires oxygen, brain, would be affected. That means that will lead to CNS dysfunction. And apart from that, other organs like kidney, gut, all of these can be involved. That means there's going to be multi-system dysfunction. Multi-system dysfunction. So AAP, American Academy of Pediatrics, included this pathology only in its definition. Firstly, it said that there should be profound acidemia, pH less than 7 in the umbilical cord blood. APGAR score at 5 minutes it used, right? So 0 to 3 APGAR score at 5 minutes, evidence of CNS dysfunction, evidence of multi-organ dysfunction. So what do you think here would be the correct answer? Firstly, umbilical arterial pH less than 7.2. It's wrong. It should be less than 7. Option B, umbilical arterial pH less than 7, profound acidemia. This is correct. Option C, APGAR score less than 5 at 1 minute. Option D, APGAR score of 0 to 3 at 1 minute. So both are wrong because I know AAP uses at 5 minutes APGAR score. It is the NNPD definition that has 1 minute. Right? So the correct answer here is option B, umbilical arterial pH less than 7, profound acidosis. Right? With that, now let's move to the next question. We have a neonate with birth asphyxia. This child develops seizures on day 1. What is the first line anti-epileptic drug according to the neonatal protocols? Levetiracetam, phenobarbital, fosphenytoin, or midazolam infusion? So the correct answer here is phenobarbital. The drug of choice for neonatal seizures is phenobarbital. So let us just revise something about the neonatal seizures. We know that neonatal seizures can be of different types. They can be subtle seizure. The name itself says subtle, very subtle things that indicate the seizures. The child could be blinking, continuously staring. There could be ocular deviation, some chewing movements. We can have focal clonic seizures, tonic seizures, myoclonic seizures. Remember, the most common type of seizure in neonatal age group is nothing but subtle seizures. Focal clonic have the best prognosis and myoclonic have the worst prognosis. Now, how you are going to manage these neonatal seizures? So, neonatal seizures, we can have different causes. Firstly, we have to rule out the most common causes, that are the metabolic causes like hypoglycemia, hypocalcemia. So whenever a child comes, we first stabilize the child, we do ABC, and in neonates, remember, we do TABC. That means firstly regulate the temperature also. So TABC, after that you check the blood sugar, calcium, it could be hypocalcemia, it could be hypoglycemia. If calcium and sugar are normal, then we go for first line anti-epileptic, that is phenobarbital. We start with 20 mg per kg per dose and dhire we elevate and go till 40. If the child is not responding, then we should do second line. Second line, we can use phenytoin or levetiracetam. If the child is not responding to that, then continuous infusion of benzodiazepines like midazolam, lorazepam is given. If the child is not responding to that also, then ultimately we give a trial of pyridoxine, because sometimes this rare pyridoxine deficiency can also cause neonatal seizures. Right? So this is the management of neonatal seizures that you need to know. Now let's move to the next question. We have a 6-month-old infant who has infantile spasm and hypsarrhythmia and also has these ash leaf spots. What is the first line treatment for the specific patient? Injection ACTH, vigabatrin, sodium valproate or oral prednisolone. So what is the correct answer over here? What is this condition? So we all know in West syndrome we have this typical triad. What is this typical triad that you see in West syndrome? I see a typical seizure. What is that? Infantile spasm, also known as salam spells. Second finding is the developmental finding. You see developmental regression. That means the child will lose the already attained milestone. If the child was previously sitting without support, now the child will forget that. And lastly, we see an EEG finding, typical EEG finding, that is hips arrhythmia. Hips arrhythmia. What is hips arrhythmia? So you see a normal EEG pattern. Hips arrhythmia means it will be very chaotic, as if some child has scribbled over it, right? Very chaotic pattern, hips arrhythmia. So here they have given infantile spasm, hips arrhythmia and also ash leaf spots. These ash leaf spots you see in tuberous sclerosis. So with that you should know these type of West syndrome. So this West syndrome broadly I can divide of two types. What are these two types? The first type is cryptogenic. The second type is symptomatic. Cryptogenic is the one where we don't have any underlying brain abnormality and usually they have good prognosis. But symptomatic usually have some underlying brain abnormality and the prognosis usually is bad. So for example, in tuberous sclerosis, you have tubers, there is some underlying parenchymal brain anomaly. Because of that, you have features of West syndrome. So normally the drug of choice here in West syndrome is, if you look at Ghai, they have mentioned ACTH or steroids. ACTH or steroids. So that means both can be given. But because this is INICET exam and you have to follow the practice that they are practicing at AIIMS. So they have preferred steroids. So remember, if the option has both ACTH and steroids, go for steroids. But what is the catch in this question? They have given tuberous sclerosis. What is the drug of choice in tuberous sclerosis? So if the option has something that is suggestive of tuberous sclerosis, remember the drug of choice here is vigabatrin. Vigabatrin. And in vigabatrin, remember the important side effect of retinal toxicity, blind as a bat. So here the correct option here is B, vigabatrin. Vigabatrin, right? So most of you have given it correct. The option B is correct, vigabatrin. Let's move to the next question. Which factor is associated with the highest risk of recurrence in a child after their first simple febrile seizure? Option A says family history of epilepsy, age less than 1 year, at onset, peak temperature of 40 degrees Celsius, duration of seizures for 10 minutes. So they have told, they're essentially asking the risk of recurrence of the febrile seizure. So firstly, what is febrile seizure? How do you define febrile seizure? Firstly, age group, 6 months to 5 years of age. Second, temperature, more than 38 or more than 100.4 degree Fahrenheit. Third, that there should not be any underlying CNS pathology. And there should not be any history of previous afebrile seizure. Right? This is the definition of febrile seizure. Now we all know we have simple febrile seizure, complex febrile seizure. But what is important is when a parent comes to you with febrile seizure and asks, what are the chances that this child is again going to throw this? So you should know the factors that we assess before telling the prognosis to the parents. So these are the tables that I've taken from Nelson textbook of pediatrics. So if you look at the risk factors for the recurrence of febrile seizures, we have certain major risk factors and minor risk factors. If no risk factor is there, if no risk factor is there, then we say that there is 12% chance that seizure will happen again. If one risk factor is there, we say 25 to 50% chances. If two risk factor is there, we say 50 to 90, 59% chances, that is 50 to 60% chances. If three or more, then 73 to 100% chances. And amongst these risk factors also, we have certain major risk factors and minor risk factors. Major include less than 1 year of age, duration of fever less than 24 hours. That means if I had fever today and today itself the child threw seizure, that means fever was not even for 2 days, 1 day fever and seizure, that is a major risk factor. And temperature between 38 to 39, that is 100.4 to 102.2 is a risk factor, major risk factor. And what about the minor? Family history. Family history of febrile seizure, family history of epilepsy. If the child had complex febrile seizure, daycare setting, if the child is in male gender, and lower serum sodium at the time of presentation. So in this question, they are asking which of these has the highest risk. So that means they are asking about the major risk factor. So can you spot the major risk factor? Yes, option B, age less than 1 year. So remember these major risk factor: age less than 1 year of age, temperature 38 to 39, and duration of fever, that is less than 24 hours. These are the major risk factor. Family history of epilepsy is a minor factor. Peak temperature 40 degrees Celsius is not there. Duration of seizure 10 minutes, not essential, right? So the major risk factor here is age less than 1 year. Option B is the correct answer over here. Chahita Verma, Busy Bee, all of you are correct, right? Option B, age less than 1 year of onset. Now let's move to the next question. A 12-year-old presents with tremors and hepatomegaly. Genetic testing is likely to show a defect in which gene? ATP7A, ATP7B, HFE gene, or CFTR gene. So what is this condition? Tremors and hepatomegaly. This is classical Wilson's disease, right? You see typical bat wings, tremors, hepatomegaly in Wilson's disease. And which genetic defect is there? We all know the genetic defect in Wilson's disease. What's that? ATP7B gene. So now let's start with this Wilson's disease revision. So what is Wilson's disease? Autosomal recessive condition. Here ATP7B gene, which is on chromosome number 13, is affected. So normally what this gene does, it codes for a copper transporter. This copper transporter actually excretes my excess copper into the bile so that it can be excreted from my body. And also it incorporates the toxic free copper that is in my body to its bound form, that is celluloplasmin, so that it becomes non-toxic. So when there is some mutation in the 7B gene, what will happen? Now my body cannot excrete excess copper, so I will have increased excess copper, increased unbound toxic copper, and celluloplasmin levels will be low. This increased copper will affect different organ. It can affect my liver, leading to chronic liver disease and cirrhosis after an age of 1 or 2 years. It can affect my eyes, leading to sunflower cataract or typical Kaiser-Fleischer rings. It can affect my joint, leading to arthralgia, joint pain. It can cause hemolysis. It can affect your brain, basal ganglia damage, leading to extrapyramidal symptoms. Neuropsychiatric manifestations can also be there, and typical bat wing tremors. The investigations include important screening investigations where we check for urinary copper and serum celluloplasmin levels. Urinary copper would be high and celluloplasmin levels would be low. Confirmatory is biopsy. We do the liver biopsy. If the copper content in the liver biopsy is more than 250 microgram per gram of the dry weight of liver, it is suggestive of Wilson's disease. Management is nothing, just preventive. We ask the child to avoid copper containing foods like chocolates, nuts, liver, shellfish, and chelation therapies by D-penicillamine can be given. Also using zinc, which can decrease the copper absorption from my body, right? So this is the animation I have sourced for you to remember Wilson's disease. Remember ATP7B gene on chromosome 13. There will be excessive accumulation of copper that affects my eyes, There will be high urinary copper, low ceruloplasmin, high free copper level. It affects my basal ganglia. You see face of panda sign on MRI and bat wing tremors. Right? Now let's move to the next question. We have a child with rheumatic fever who has no carditis. How long should the secondary prophylaxis continue? Options are 5 years of age or until age 18, whichever is longer. Option B says 10 years of age or until age 10 years or age 25, whichever is longer, for lifetime. And option D says 5 years or until age 21. So what do you think is the correct answer over here? Rheumatic fever, no carditis, secondary prophylaxis. So firstly, let's understand why do we need the secondary prophylaxis. I know the child with rheumatic fever has inflammation all over the body happening, especially carditis. And this carditis can in future lead to mitral valve issues leading to rheumatic heart disease. So to prevent that to happen, I give the secondary prophylaxis, right? So secondary prophylaxis, the drugs that we use include penicillin, benzyl penicillin, oral penicillin. I have two options. So I will tell the child either you come every 3 to 4 weeks and get this one injection of long lasting penicillin, benzyl penicillin with me. If the child is less than 30 kg, I'll give 6 lakh international units. After that, after more than 30 kg, I will give 12 lakh international units, right? This is simple. The child has to come every month and get this one shot of penicillin, benzyl penicillin. But if the child does not want injection, I can prescribe oral penicillin V. This the child has to take twice daily, 250 mg. If the child is allergic to penicillin, then the other alternative is erythromycin. The dosage is similar to the oral penicillin, that is 250 mg twice a day. So these are the drugs that you are going to give. What is important for you in the exams is the duration, for how long the child has to take this penicillins or erythromycin. So remember, if there is no carditis, then for the next 5 years or 18 years of age, whichever is later. For example, if the child is 12 years of age, then the next 5 years he will be 17, but the criteria says whichever is later. That means I will ask the child to get this till 18 years of age. That means another 6 years. Similarly, if the carditis is there, for the next 10 years or 25 years of age, whichever is later. And if there is established rheumatic heart disease or some surgical complication happening, then lifelong the child has to take this prophylaxis. So in this question, there was no carditis. So what is the correct answer? No carditis, 5 years or 18 years of age, whichever is longer. Option A. Right, so Ritika, you are correct. It's 5 years or until age 18. Now let's move to the next question. What is the most common cause of barking cough and steeple sign on X-ray in a 2-year-old? What is this? Steeple sign, barking cough, 2-year-old child. These are very classical of the condition known as croup, that is laryngotracheobronchitis. And what is the most common organism causing this laryngotracheobronchitis? It's para-influenza virus. Option B. Right? All other viruses can also cause this, but most common cause is para-influenza virus. So now let us revise this condition, croup or laryngotracheobronchitis. So what is the age group in which we see this commonly? 6 months to 5 years of age. It is a viral illness. Most common cause is para-influenza virus. This child will present to you with the viral prodrome. There will be low-grade fever, stridor, and typical cough. What is this cough? This is barking cough, seal-like cough or brassy cough. The treatment here will depend upon the severity. If the child just has stridor on exertion, there is no sign of respiratory distress, normal saturation, that means this child has mild croup. Here, just single dose of oral dexamethasone in the dosage of 0.15 to 0.6 mg per kg is given. But if the child has stridor on rest, has signs of respiratory distress like tachypnea, retractions, then this comes under the treatment category where we give oxygen inhalation and a racemic mixture of epinephrine nebulization. If the saturation is normal, this is moderate group. If saturation is less than 92% on room air, this is severe. In both the cases, you are going to give oxygen and nebulization with racemic epinephrine mixture. You see this typical X-ray. You can see this tip sign, steeple sign, pencil tip sign, steeple sign, temple top sign. All of these are the different names of the sign. This we see classically in croup or laryngeotracheobronchitis, right? Now, a similar condition which is often compared with laryngeotracheobronchitis is acute epiglottitis. In which age group do you see this? You see in 1 to 3 years of age. Here the cause is bacterial cause, Haemophilus influenza type B. What are the clinical feature? This child will be very toxic looking. A bacterial infection is very bad. So there will be high grade fever. This child will be toxic looking, will have muffled voice. Can you see how the child is sitting? The posture is known as tripod posture. The child is resting on both of his arms and leaning forward. This is tripod posture. On X-ray, you see thumb sign. Normally, you see epiglottis like this. Here, the epiglottis is swollen like a thumb. So this is known as thumb sign. The treatment here will be to firstly stabilize this child. We do ABC, airway, breathing, circulation, and give antibiotics as this is a viral illness. We start with third generation cephalosporins. Right? So these two are important infections whenever we are studying the pediatric respiratory system. This you must have studied in ENT too, but here it needs a revision because these two are two important previous year questions that you need to know for your exams. Now let's move to the next question. We have a 2-year-old boy who came with a history of blue lips and blue skin. That means this child has a history of cyanosis. Auscultation revealed an ejection systolic murmur at pulmonary area. That means this is a pulmonary stenosis murmur probably. Echocardiography was done next day that revealed tetralogy of Fallot-Topf. The severity of cyanosis and TOF is dependent upon which of the following factors? RVH, that is right ventricular hypertrophy, overriding of aorta, atrial septal defect, or pulmonary stenosis. So they have typically given you the 4 features of the tetralogy. So tetralogy in the name itself has, it is going to have 4 things, tetrad, right? This is the tetrad which they have given in the options. We have right ventricular hypertrophy, we have ventricular septal defect, they have given atrial septal, we have ventricular septal defect, overriding of aorta, and pulmonary stenosis. So what is happening essentially over here? If I make a line diagram, this is the right side of my heart, this is the left side. We have this right atrium, right ventricle. We have left atrium, left ventricle. So what all features do we have here? We have right ventricular hypertrophy. I have hypertrophy the right side. We have this stenosis, pulmonary stenosis, right? We have ventricular, we have a ventricular septal defect. So this will be the VSD, and we have an overriding aorta like this, right? So what is essentially happening in this condition? So I know right side of my heart will get deoxygenated blood from my body and send it to the lungs for oxygenation. And oxygenated blood comes to the left side and gives it to my body. What is happening over here? Because there is obstruction to the flow of deoxygenated blood on the right side, what will happen? Some of the blood from the right side will gain access to the left side. There is essentially right to left shunt. So more the left to right, more the right to left shunt, more the body will receive the deoxygenated blood, more the body will get cyanosed. So that means if this obstruction is more and more of the blood will be shunted. So that means the severity of pulmonary stenosis will tell me the severity of the cyanosis. More severe the stenosis, more will be the cyanosis. So the straight away answer here is going to be pulmonary stenosis, right? Pulmonary stenosis. Right? Now let's move to the next question. A child with Down syndrome is screened for comorbidities. Which of the following is the most common congenital heart defect associated with this chromosomal abnormality? Ventricular septal defect, endocardial cushion defect, patent ductus arteriosus, tetralogy of Falley. A very straight away question. We all know the most common congenital heart defect in Down syndrome is endocardial cushion defect. Now let's revise Down syndrome. What is Down syndrome? Down syndrome is trisomy 21. That means I have an additional chromosome 21. What are the typical features? There is growth failure, mental retardation. We have typical faces. In that we have broad flat face. There is slanting of the eyes, that is known as mongoloid slant, where the outer cantha is pointing upward. We have epicanthal fold, short nose. In hands you have simian crease, a protruding tongue. You have heart defects like endocardial cushion defects. You have intestinal atrasias, you have sandal gap, all of these things you have, right? With that, we come with this table. This table is very essential for your exams, as in this question they have asked what is the most common genetic congenital heart defect in Down syndrome. Other genetic syndromes can also have certain congenital heart defects. So we are making this table down here just to revise it before the exams. So Down syndrome we have just read, it's endocardial cushion defect. Which CHD do you see in Turner syndrome? We see left-sided heart defect. What do I mean by left-sided heart defect? I have left side, left atrium, left ventricle, and aorta. So we have bicuspid aortic valve or coarctation of aorta. These are the common associated CHD. Then we have Noonan syndrome, where we see right-sided heart defects. On the right side you have right atrium, right ventricle, pulmonary artery. So pulmonary stenosis. In Edward syndrome and Patau syndrome, what is Edward? Trisomy 18. What is Patau? Trisomy 13. In both of these, which is the most common associated CHD? It's ventricular septal defect. Then you have DiGeorge syndrome. In DiGeorge syndrome, you have conotruncal defects. And in Williams syndrome, we see supravalvular AS, supravalvular aortic stenosis. So very important table to revise before your exam. What are the common associated congenital heart disease or different genetic syndromes? With that, yet another important table. Some of the congenital heart diseases are associated with certain maternal conditions. For example, gestational diabetes. If mother has gestational diabetes, then the child has chances of developing CHD. What type of CHD? The most common CHD is ventricular septal defect, and the most specific one associated with mothers with gestational diabetes is transposition of great arteries. In rubella, if the mother has rubella, the child can have congenital rubella syndrome, and in that we see patent ductus arteriosus. If mother is consuming alcohol during pregnancy or consuming phenytoin, then the child can have fetal alcohol syndrome or fetal hydantoin syndrome. In both of these, again, VSD is a common associated congenital heart defects. If mother is on lithium for the bipolar disorder, the child can develop Epstein anomaly. If mother has SLE, antero-anterior antibodies, then the child can have neonatal bradycardia or heart blocks, right? So these two important tables are for your exam: commonly associated CHD with genetic syndromes and with maternal conditions. Don't forget to revise before your exams. Right, now let's move to the next question. Which of the following blood gas and electrolytes will collaborate with IHPS, that is infantile hypertrophic pyloric stenosis? So we have different values over here. We have pH, PCO2, potassium, bicarbonate. Firstly, let us revise this condition, IHPS. So what is happening over here? Idiopathic or infantile hypertrophic pyloric stenosis. So this is my stomach. This is the pyloric end that leads to my further duodenum. So what is happening over here? There is hypertrophy of the circular muscles at the level of pyloric end. So that means there is gastric outlet obstruction. Because of that, what will happen? Because of this gastric outlet obstruction, what will happen? The child is going to have vomiting. Everything that goes in will come out. So child is going to have vomiting. These vomiting are projectile vomiting. These will be bilious or non-bilious. Bile is secreted down in the duodenum. So this is going to be non-bilious vomiting. And on examination, this hardened part, this hypertrophic part, appears like an olive-shaped mass that moves with peristalsis right to left. Right? So these are the clinical scenario usually associated with the first-born male child. Right? So projectile vomiting, non-bilious vomiting. Now the examiner is asking what are the metabolic problems that are going to happen in this child. So as the child is vomiting out, that means all the gastric juice will be vomiting out, all the HCl will be vomiting out. So there will be loss of H+, that means there will be alkalosis. There will be loss of chloride, there will be hypochloremia. Also there will be loss of water, there will be dehydration. That will be sensed by my kidneys. They will start secreting, RAS will be activated, and under the influence of aldosterone, what will happen? There will be conservation of the sodium and H+, K+ will be excreted. That means there will be paradoxical aciduria. H+ is secreted in the urine, so aciduria and hypokalemia. So the overall picture here is that you have metabolic alkalosis, hypochloremia, hypokalemia and paradoxical aciduria. So let's go back into our options. Firstly, I know I'm going to have alkalosis. So this option is excluded and this option is also excluded because this is acidosis, this is normal pH. I'm confused between option C and D. Look at the value of potassium. I know I am going to have hypokalemia. So the best option here is option C. I have hypokalemia and metabolic alkalosis. So option C is the correct answer. Rakshak is right. It's option C. Again, an important image-based question. This is nothing but IHPS. You look at the pyloric end, it's thickened. So what is the cutoff? So if the pyloric thickness is more than 4 mm and pyloric length is more than 16 mm, it is diagnostic of IHPS. Right? With that, now let's move to the next question. We have a 6-year-old child who presents with the symptoms of dehydration. You are evaluating the clinical signs to confirm the diagnosis. Which of the following is a reliable sign of some dehydration and severe acute malnutrition? The options we have are increased thirst, sunken eyes, skin pinch that goes black slowly, or altered sensorium. What do you think is the correct answer? So very important question for your exams, dehydration assessment and management. So whenever a child comes to you with loose stools, vomiting, firstly, what do? We assess the status of dehydration and manage accordingly. Right? So how are you going to assess dehydration? Firstly, we look at the consciousness of this child. If the child is alert, if the child's thirst is normal, what do I mean by normal thirst? If I offer water to this child drinks very calmly, very gentleman-like, that means the thirst is normal. If you do skin pinch, that means you'll elevate the skin and look for the recoil. If the skin pinch has immediate recoil, if the eyes look normal, that means the child has no dehydration, right? An alert looking child with normal thirst, immediate skin recoil, normal eyes. This is a no dehydration child. Here you give plan A. Also, here the mucosa, oral mucosa will be moist. Oral mucosa will be moist. Now let's go to the second scenario, that is some dehydration. The name itself has some degree of dehydration has started. So because dehydration has started, this child will now be irritable. If you offer water to this child will drink very eagerly, as if the child is thirsty for a while. So this child drinks eagerly, irritable child that drinks eagerly. If you look at the skin recoil, because this child has some dehydration, this skin will go slowly, right? This recoil would be slow, but it will go within 2 seconds. Eyes look sunken, mucosa is dry. Here we label this child as some dehydration and give plan B. Then we have severe dehydration. When the child is severely dehydrated, now he will be totally comatose, right? Totally comatose, very dull, very lethargic. So if the child is very lethargic, comatose, that means this child has severe dehydration. If you offer water to this child, the child won't be able to drink water. How a lethargic or comatose child will drink water? So he is unable to drink. Skin pinch will go very slowly, more than 2 seconds it will take for recoil. Eyes look very sunken. Mucosa will be very dry. Here we go for plan C. Plan C. So now let's look at plan A, plan B, plan C. So plan A, I told you, is for no dehydration. This child has no dehydration. He is very alert, very gently, calmly drinking water. So I have to do nothing over here, right? The child has good hydration status, no dehydration. Just I have to replace whatever losses the child is having, right? So I will ask the mother to give oral rehydration solution, ORS, for the replacement of losses. We give 10 ml per kg per loose stool. So if the child is passing one loose stool, a 10 kg child, I will ask the mother to give 10 into 10, that is 100 ml per loose stool. Now comes plan B for some dehydration. So some dehydration child can also drink orally. He has good thirst. So here again I am going to give ORS. But here, because some degree of dehydration has settled in, firstly I have to rehydrate this child. How do you rehydrate? We give 75 ml per kg of the ORS over 4 hours, over the next 4 hours. So if it is a 10 kg child, I will give 750 ml over the next 4 hours. Apart from that, replacement of the losses, that is 10 ml per kg, is to be given. And also you have to ensure that normal maintenance fluid the child is receiving. Lastly, we have plan C. This is for severe dehydration. Now the severe dehydration child cannot have ORS from the mouth. He's very lethargic, very comatose. So I have to give fluids here, IV. So we give IV therapy. We prefer Ringer lactate solution, RL. Here rehydration is done by 100 ml per kg. If the child is less than 1 year of age, then we firstly give this 30 ml per kg bolus over 1 hour, followed by remaining 70 ml per kg in the next 5 hours. After 1 year, we can give this in half an hour and remaining in 2.5 hours. Rest, replacement of the losses and maintenance fluid is normal. The same as plan B, right? But everything here is going to go through IV until unless the child starts drinking orally, right? With that, we move to the next, come back to our question. This question said that this child had dehydration, and which of these would be a reliable sign for some dehydration in SAM? So I know what are the signs of some dehydration. There will be irritability, the child will have increased thirst, the child will have sunken eyes, will have skin pinch slow less than 2 seconds. So let's look at these options. Increased thirst is suggestive of SAM. Sunken eyes is suggestive of SAM. Skin pinch increased thirst is suggestive of some dehydration. Sunken eyes, some dehydration. Skin pinch that goes black slowly, again some dehydration. Altered sensorium is severe dehydration. So one option we have ruled out. Now let's look at the other 3 options. They are saying that in SAM, which of these would be most reliable? So remember what happens in SAM? SAM was a very malnourished child, severely acute malnutrition, very wasted child, so no subcutaneous fat whatsoever. So eyes look sunken as if, right? So sunken eyes won't be a reliable sign over there. Also, they don't have subcutaneous fat. So if I do the skin pinch, it might go slowly because of that loss of subcutaneous fat. So option B and C would be something which would be doubtful in cases of SAM. In SAM, the most reliable sign would be increased thirst. Having increased thirst is a suggestive and more reliable sign in cases of SAM. So option A, that is increased thirst, would be the right answer over here. Right? Option A. Now let's move to the next question. A follow-up question. Again, a child presents to your clinic with 3 days of vomiting, watery diarrhea, and altered sensorium. So a child with loose stools vomiting now comes to you with the altered sensorium. What would be the possible diagnosis? Options we have are hyponatremia, cerebral venous thrombosis, and HUS, that is hemolytic uremic syndrome. So what do you think is the correct answer over here? So remember, whenever a child with loose stools, vomiting, presents with some CNS manifestation, it could be altered sensorium, it could be seizures. What are the causes? A very simple statement is given in your guide textbook of pediatrics, and you should not ignore that statement. So what are the causes? Remember, first cause is sodium, hyponatremia or hypernatremia. Second cause is sugar, hypoglycemia. Third cause is meningitis, encephalitis. Fourth cause, your cerebral venous sinus thrombosis. Or it could be very severe dehydration, because of that there is altered sensorium. Or it could be febrile seizure, right? So remember, this is the convulsions or altered sensorium features: hyponatremia, hypoglycemia, hypocalcemia following bicarbonate therapy, encephalitis, meningitis, febrile seizure, central venous or sagittal sinus thrombosis. So here hyponatremia can be the cause, hyponatremia can be cause, cerebral venous thrombosis can be the cause, but HUS is not listed. So the most correct answer here would be 1, 2, 3, that is option B. Right? So remember, a child with vomiting, loose stools, if presents to you with CNS manifestation, it could be altered sensorium, convulsions. Remember these causes: hyponatremia, hypoglycemia, hypocalcemia, usually following the bicarbonate therapy for acidosis, encephalitis, meningitis, febrile seizure, and sagittal sinus or cerebral venous thrombosis. With that, now let's move to another question. I have a 9-month-old infant who presents with cough and fever for 2 days. On examination, the respiratory rate is 48 per minute. There is no chest indrawing and no danger signs. According to the IMNCI guidelines, how should this child be classified and managed? So examiner is basically testing whether you know IMNCI guidelines or not. So before we learn and revise IMNCI guidelines, we should know what is the normal criteria for fast breathing. Remember, in the first 2 months, more than 60 per minute, 2 to 12 months, more than 50, after 12 months, 40. So 60, 50, 40, less than 2 months, 2 months to 1 year, after 1 year. This is the criteria for fast breathing. And what are the danger signs? If the child is unable to drink water, if the child has convulsions, if it is a calm child with stridor, if it is an abnormally sleepy child, if the child has severe malnutrition, all of these are danger signs, right? So like we discussed, no dehydration, some dehydration, severe dehydration. Here we have no pneumonia, pneumonia, severe pneumonia. So no pneumonia child will just have features like cold, cough, fever, right? So here I'm going to have cold, cough, fever. The respiratory rate will be normal, no sign of respiratory distress. Here just home-based treatment, symptomatic treatment. We can give paracetamol, we can nebulize with salbutamol if wheeze is there. Home-based conservative treatment is given. What about pneumonia? In pneumonia, along with this cold, cough, fever, now the child will either have tachypnea or retractions, right? This child will have fast breathing and or retractions. So here the treatment will include giving oral antibiotics. Oral antibiotics like amoxicillin for 5 days, and we asked up for follow-up. But if there is any of the danger signs, then this is severe pneumonia. Here we give injectable antibiotic, ampicillin, gentamicin, and refer the patient. So let's go back into this scenario. Here we have 9-month-old. So what is the criteria for tachypnea or fast breathing for a 9-month-old? More than 50. Here the respiratory rate is 48. That means this child does not have fast breathing. Also this child does not have any chest indrawing or danger signs. So this is no pneumonia. I just give paracetamol, home care, and counsel the mother. Option C is correct, right? So most of you have given the correct answer. Yes, majority of the previous year questions are covered over here. Definitely, I cannot go on and dissect each and every topic, but broadly, what all topics that INI people usually test, I have tried to include that. So with that, IMNCI guidelines have been covered. Now let's move to the next question. So you are evaluating a child with suspected congenital heart defect. According to NIDA's criteria, what is the minimum requirement to make a clinical diagnosis? 1 major, 1 minor. 1 major or 2 minor, 2 major and 1 minor, 2 major or 3 minor. So usually what all criteria do we read? We usually have 1 major criteria and along with that 2 minor criteria or 1 minor criteria. NADA's criteria is the only criteria that has 1 major or 2 minor. Let's go and revise this NADA's criteria. You can see this is a snippet from Ghai textbook. Presence of 1 major or 2 minor is essential for indicating the presence of heart disease. So let us revise what are these major criteria and what are these minor criteria. So major criteria, first, remember first two are related to murmur. So a systolic murmur, which is of grade 3 or more, is a major criteria, and any diastolic murmur is a major criteria. Then we have CC. What do I mean by CC? C is for cyanosis. C is for congestive heart failure. So these are the 4 major criteria. Remember, 2 are the murmur criteria: systolic murmur grade 3 or more and diastolic murmur. And then we have CC, cyanosis and congestive cardiac failure. So this is the major criteria. What about minor? I told you systolic murmur grade 3 or more is major. So anything that is grade 3, less than grade 3 is minor. Apart from that, all of the clinical assessment findings like abnormal S2, abnormal ECG, abnormal chest X-ray, abnormal BP, all of these would be minor criteria, right? You can see abnormal echocardiogram, ECG, abnormal X-ray, abnormal blood pressure, abnormal second heart sound. All of these are minor criteria, right? So this is how we suspect in suspecting patients with congenital heart disease, we employ this NADA's criteria. Remember, I need 1 major or 2 minor. 1 major or 2 minors. The correct option here is B, 1 major, 2 minor. Let's move to the next question. A child received a DPT vaccine at 6 weeks and cried inconsolably. Now the child is 10 weeks old. What is the best step here? Option A says don't give DPT. Option B says give DPT. Option C says don't give only DT. And option D says give only TT. So what do you think would be the correct answer over here? So I know this DPT vaccine is a part of the pentavalent vaccine given at 6, 10 and 14 weeks. This vaccine has a lot of adverse reactions, adverse effect. What do we need to know over here is what is the contraindication of this vaccine and what are the precautions of these vaccines. So I have two terms over here, contraindication and precaution. Contraindication means if such a scenario happens, I won't give next dose. That means contraindication. And what do you mean by precaution? Precaution means, okay, some event happened, but let us give the next dose. If it repeats on the next dose, I won't give any further doses. So this is precaution, right? So with that, now let's learn the scenarios where I'm not going to give. That means the next dose will be contraindicated. And what are the scenarios where I will have a precaution? That means I will give the next dose, but if it repeats at the next dose, I won't give any subsequent doses. So let's understand the adverse reaction of DPT. The first most common reaction is local pain at that injection site, fever, swelling. And what are the rare adverse reactions? HHE, that is hyperresponsive hypertensive episode, inconsolable cry, very high grade fever, more than 40.5 degrees Celsius, seizures, encephalopathy. So what are the contraindications? Contraindications means I'm not going to give the next dose. If there is anaphylaxis after the previous dose, I won't give. If there is encephalopathy within the 7 days of the previous dose, I won't give. And what is the relative contraindication? If there's a progressive neurological disease, then we give DT or TD. That means I'm going to exclude the pertussis, which is notorious for this neurological side effects. So I'm going to give DT or TD instead. Remember, the stable neurological diseases like CP, epilepsy, they can still receive that DPT vaccine. Then what is precaution? Precaution include if there is fever more than 40.5 within 48 hours, if there is an HHE episode within 48 hours, if there is persistent inconsolable cry, that means more than 3 hours the child continuously cried within the 48 hours of receiving the vaccine, and lastly if there is seizure within 72 hours of receiving the vaccine. These are the precautions. So remember 4 precautions: very high grade fever more than 40.5 within 48 hours, HHE within the 48 hours, persistent inconsolable cry for more than 3 hours within the 48 hours of receiving the vaccine, and seizures for less than 72 hours. Right? If any of this event happens with the subsequent dose, further doses are contraindicated. So in this question, they gave us one of the precautionary statement, that is the child cried inconsolably. So what you are going to do? I'm going to give DPT. You are going to give DPT at 10 weeks. If this repeats at 10 weeks, further subsequent doses I won't give. Right? So the correct answer here is B, DPT. With that, we come to the end of this session. If there is any doubt, please drop that down in the comment section. I'll be more than happy to repeat that concept and learn together. If not, then we can end the session. If there is any doubt, please drop down in the comment section. PDF will be posted on your PW MedEd app. You can see and also in the comment, the pinned comment, they'll be dropping down that once the session ends. So you can have that PDF over there. Anything else? If the child has seizure within the 72 hours, that is a precaution, not a contraindication. Progressive neurological disease would be a relative contraindication. So seizures per se is not a contraindication, right? You can still give. The most important unit for INICT is neonatology. Don't forget to revise NRP. Undoubtedly, in each and every session, one question from NRP here and there is there, right? It could be as simple as giving free flow oxygen, or some ambu bag, or some chest compressions timeline or something like that. But they're going to ask about NRP. So NRP through and through you should know. You will get the PDF once the session is over. Check the pinned comment. The pinned comment will link you to the PW MedEd app where you will get the PDF. Right? Okay, so I think there is no more doubt, and we can end the session. Thank you for being so cordial throughout the session and being so interactive. I wish you all the best for your exam. Don't forget to revise these previous year questions that we are discussing. Each and every faculty have curated this session specially so that you can just get a gist of this exam. This exam, INICT exam, is a very doable exam, a very hopeful exam. If you are very sincere and you are directed towards the good material that has adequate amount of previous year questions and topics that are asked in this exam, there's no one stopping you to get that rank, right? And getting into Central Institutes is dream of all of us, and you can achieve that dream. All the best for your exam. Thank you. We are ending the session now. Have a good evening. Have a good dinner. Bye bye.